I'm Kimberly C. Paul. As I travel throughout each state, I realize that death is just a moment. It is how we live until that moment that matters. Finding connection with friends, family, and complete strangers. Journey with me. This is the Live Well, Die Well Tour. I'm here with Martha Calihan, Dr. Martha Calihan. I just finished reading your book. What a fabulous story. But before we go into that, I thought I would allow us to talk a little bit about your experience with your husband, why we're here, and why we're talking about your husband, which eventually became a really cool story about how a physician became a caregiver. And through your book, because I just recently read it, it really opened your eyes to end of life. But let's first start with your story about your husband. Tell me his name. And let's talk about why we're here talking to one another today, because your husband had a diagnosis and it started with this journey with you and him. So let's go back. Tell us about what occurred with your husband's diagnosis and walk us through that.
So Charles really had two issues. Interestingly, he had colon cancer, which didn't really play into his final illness, which is kind of ironic. But he had very significant cardiovascular disease. And in the last year of his life, which is really what I chronicle in this book, he had 6 ICU admissions with complications from that. And ultimately, as the situation became increasingly more clear that there were not great long-term options, he reached the place where he decided he wanted to stop further treatment and just be at home. Watching that, participating in that, being his wife, being a trained physician, really shone the light on that process of deciding when other options need to be presented. I don't think, my personal bias is that as a culture in general, I think we're pretty bad at death, and we may talk more about that later. But this process that he and I and we as a family went through, it was gradual. When we started out, incredible, heroic things were done to save his limbs, to save his life, for which I was and am extremely grateful. We had a fabulous team of people taking care of him. As the year went on and as the complications piled on, we moved from where it made sense to keep doing more procedures to where it made more sense to Charles and to us, but most importantly to Charles, to take a different approach and to realize that he'd reached the end.
How was that? I mean, you see things like this. You must have seen things like this through the eyes of your practice being a physician. Talk to me a little bit. How's it different being that you're still the physician, but being the wife too?
Right. And yes, I have worked with lots of people in their final illnesses and in their dying process. I was trained as a family physician, so that's part of what we do. And I will say, I always thought that work was particularly wonderful work to do. I was always drawn towards that sort of end of life care with people. When it was our turn, and it really wasn't us, although it was Charles, I mean, obviously it's different because the emotions are so different. But I think that what I was able to do was to see with dual vantage points and help facilitate the conversations. And really that is what I did, because his team, like many medical teams, didn't want to go there. There were always more things that can be offered, things that can be done. And is as often the case, you have a bunch of different people all working on the same case, everybody offering a little bit of this, a little bit of that, a little bit of this. And somewhere in the book, I think I talked about the fact that, I don't think anyone stopped and thought about, okay, who's the man who's having all these issues? And, has anyone sat down and talked to Charles about where he is, what it looks like, what the reality is, and talk to him about helping him make some choices?
Were you able, as a wife and a caregiver, did you and your husband, Charles, have some of those conversations?
We had endless conversations, and all the way through the process. And then particularly once he was home and we made that decision and we were home with hospice care, we talked about his inevitable death over and over and over again. It was part of the process, but we talked about it all year long. It was one of the real gifts of the whole experience, was our ability to talk about it. And, that was one of the enormous gifts that he gave us as a family, because we all talked about it. He talked about it with us as a family.
And how did that go? I mean, it's really interesting because sometimes I talk to family members and well, I'm trying to talk to my daughter about, advanced care planning and my advanced directives, and my kids don't want to hear it. And then I hear the kids sometimes on the other side saying, look, I work in hospice and palliative care and I'm trying to talk to my parents about advanced directives. They just don't want to hear it. Did you feel like your family was open to meeting your husband where he was at? Because we in palliative care and hospice, I've been in this business 22 years. We are constantly reminding ourselves it's not our death, and we have to stop thinking and projecting what we think is best for the patient onto them. And so, I'm sure you being a physician, I'm just wondering if some of that occurred.
First of all, I agree with you completely. You do have to meet people where they are. And maybe it was luck. Charles was there. Charles wanted to talk about it. And that's what I have found so often with families. The person in the bed says, oh, don't tell my spouse that, that I'm going to die. I don't want to upset them. And the spouse is standing in the hall saying, don't tell my spouse that I'm going to die because I don't want to upset him. And you're wasting so much valuable time. Maybe I pushed the issue. Maybe Charles was just more open than some other people. We talked about it a lot, and as a family.
But your husband wasn't not in the medical field.
No, he was an architect and an artist.
Oh wow! So yeah, even though you were, he was still open about that, and you must see that as a gift.
It was a huge gift. Yeah. We had this conversation that I talk about in the book. And I remember my sister saying, well, what are you going to serve for breakfast, for the death breakfast? Because he made it very clear, everybody was home. It was near Christmas time. And he made it very clear that he wanted like a family meeting the following morning. And we all sat in the living room. So it was Charles, it was me, it was our son, it was his two older sons, my stepsons, and one of the granddaughters. And we sat there as a family, and he just said, we all know I'm going to die. We just don't know how soon. I hope it's not soon, but this is what's important to me, and this is what I want. And I don't want dialysis. I don't want this. I don't want that. And some levity in there, like I don't think anybody would want my organs after all this, and what I want done and what I don't want done. And our son at that point looked at him and said, well, Dad, we could just have you taxidermied and you could just stay in that chair. So, I mean, that's a gift, right? The whole family talking, laughing, crying talking about this man's inevitable death. He still lived another 4 months, but
Oh, wow.
that was the platform that was set. And even as a blended family, which certainly, historically can have its challenges, we never had to have another conversation amongst ourselves about what we would or wouldn't do as Charles was actually dying, because he had been crystal clear.
And do you feel like hearing that from the actual person who is going through this process, it must have been so important, because if anyone ever wanted to stop, you still heard his voice of what he wanted. I think that's really important, don't you?
Absolutely, I do. And I think for Charles, I think it was tremendously empowering, because he was very clear that he was going to make the decisions when he wanted to make the decisions. You've been in this work. It's the opportunity to live your death, which is, what I call the book. But that's a beautiful, magnificent, sad, heroic, poignant, beautiful space. And it breaks my heart when people miss that because they're too afraid to have the conversation.
And we've talked a little bit about your book, and what I loved about your book, it's called A Death Lived. And I want to ask you why that title, because I love it, because I've seen many deaths that are lived, because it makes sense being in this field. But a lot of people who haven't had the exposure to death and dying, like the both of us, I'm sure they question, like, a death lived. What is that? And how did you come up with that title?
I don't remember how I came up with it specifically, but it is the message of the fact that Charles did, and other people can, live their death, live that experience. He lived it fully. We had an incredibly rich couple of months in that final hospice phase of his dying process, but he was present to it. He was present with it. We all were.
It was beautiful.
In so many ways, it was a beautiful experience.
Do you feel that your husband leaning into it and accepting was his way of bringing you guys along that journey as well? Because I've seen many patients throughout my years not lean into it, and contemplate, like, treatment, and you see what is happening on the outside is prolonging of suffering versus, what they feel is going to prolong their life. Did it help for your husband to accept what was going on and lean into it? And how did that affect you?
I think it did help him. We worked with a close friend who was the hospice doctor, who many conversations, just talking with Charles, talking with us about where he saw that we were on the continuum, never saying, oh, well, I think you have X amount of weeks or months or whatever, but these are the kinds of things that you might expect. These are the kinds of issues that might come up. Here are some of the possible solutions. No pressure. You don't have to make any decisions, just a lot of talking, a gentleness, and he had a tremendous gift of creating the space for us to have those conversations and to have those even internal dialogues.
That's talent. And to make individuals feel comfortable that it's okay to ask questions and permission to say things. It's a very vulnerable time, and I think that's why so many of the hospice and palliative care patients, they've taught me more about living than about my own death. But the interesting thing is that, you and I are not alone in some of our wonderful experiences around end of life. But not many choose to write a book about it. Why was it important for you to share your story?
Well, two reasons, because I think Charles did such a magnificent job it just felt to me I never doubted the fact that it really needed to be shared. It was such a gift. But the other thing is I feel passionate about the fact that I want to help people realize the value of having these conversations. I'd like it to be part of people's sort of, I don't know, annual check-in with, you talk, we do the financial and legal stuff. I think it's less scary. People have a will, they talk to the financial guy,
It's almost like
they
business.
make,
That's business.
it's like business.
Yeah. But
Right.
don't talk to me
No,
about my
no
heart.
emotion. Right. But don't, talk about what I might want. And if there's anything that I am able to do to help open up this conversation about end of life and dying, I do a lot of work in mindfulness.
Mm.
And what I am seeing is that I think we ought to expand the conversation about mindfulness to include mindful dying.
I love that.
Yeah.
I love that. This is, I think there's a lot of challenges. We human beings feel we're destination thinkers, so we can't destinate our way out of our thinking about our mortality. But also, and we have a lot of work to do in getting just human beings able to live in the moment as well as plan for that moment. But you are a physician. There's a lot of physicians that are beginning to have really open dialogue and inspire their patients to think about things, the what if scenarios. But then there's so many that run from it. How can we help our fellow clinicians, even empower them to do their advanced directives? Because we're so bad at it in the healthcare field. Only 30% have even begun the conversation, but we see it and preach it every day.
Yeah.
What are some of your thoughts about that?
It's such such an oxymoron, isn't it? I mean, and part of it is our training, right? We're trained to do stuff and save people, and we're good at that, but it's not always appropriate. And it's so hard to get it out of the sort of value judgment piece of the equation. And I think the first thing is just to, and I don't know actually what kind of training they're doing in medical education these days. I know we had zero of it, but that was a while ago. So I hope it's better. But I had one of Charles's physicians actually tell me later that he was never able to see a patient death as anything but his personal failure. And that broke my heart for him. I mean, what a burden. And forgive me, it's a little arrogant. I mean,
right?
Newsflash, we're each going to die.
Right.
It's the only thing that is certain from the moment we're born. So I just wish that we could. It's naive to think people won't be afraid. That's a different piece of the equation. But acknowledge it, admit it. Let's talk about it. And some of that is, I think, we in the medical field are not very good at describing what the different things that we do and offer look like. You start to hear a little bit more now about, well, what does it mean when somebody's coded or resuscitated? It's pretty gruesome, particularly if you're old and frail. And we have to remember that these are totally different conversations in different situations, right?
Exactly.
Somebody young, and so one size does not fit all. But the vast majority of the time, we're talking about older people, most often with one or several diagnoses. And at some point, you just got to stop playing the game of it's all going to get better and just shift into, okay, if this doesn't get better, what's important to you? What are your values? And for some people, maybe it's do absolutely everything that's available, and that's fine. It's just a question of talking it through. What does it mean? We were Charles and I had lots of graphic discussions, and probably because we were together all the way through my medical training, he was very well versed in some of those things, but it wasn't ever an issue, but he certainly didn't want to consider things like feeding tubes and being coded and being intubated. And that said, he had a couple of things along the way, not in the final illness, but surgeries and stuff. And he, he was intubated for a couple of days, and their different situations warrant different discussions.
I totally agree with you. And you mentioned this word fear. I think fear gets a bad rap. It's okay to be afraid and allow fear to be in the room as long as it doesn't paralyze you. Like, even on great adventures, people have fear. And it's this innate ability to know what's going on, and fear is a good thing.
It is. Yeah.
Yeah, right. But I'm being afraid of the inevitable. Like us sitting here today, we will die.
Yes.
One day. And the only thing I feel, if I'm not tragically killed by these crazy drivers in Denver, or doing adventurous things, the only thing I do feel like I might have control of is how and where. When is this someone else makes that decision? If you're spiritual or, feel like a disease process, but it's how and where. And I think that so many people want to grasp and control an illness. And sometimes, no matter what we do, we're unable to do that.
Exactly.
And right. And I feel very strongly that even us in working with dying patients, or let's just say patients with serious illnesses, I mean, we fear that their death is that failure, like you mentioned before. But I think I'm a seeker of the truth, that I want the patient, and I want to get clinicians, no matter what their title is in this world, to say, look, here are the options, but here are the most likely outcomes of those options. Because no matter what you do, if you're facing a serious illness and you're dying, those options will either quicken that, because you're looking for curative, and we don't have the courage or the bravery to say curative is not. We can hope for that.
Yeah.
Miracles happen every day, and I'm the kind of person that I've seen them and I get it. But when people are very nervous around, I don't want my husband to die, we lean into that and we come up with, I believe, false hope. Let's do this. Let's do that. Knowing that this or that will not change the outcome. How do we in our field get better at having these conversations, truthful conversations with our patients?
Yeah. And you're right, I think. And that knowing that those options are not going to change the outcome, that feels at its worst disingenuous, right? That those things are still being offered, without the parenthetical, hey, this is a possibility, but never seen it work, or one in a
Right.
or. But I really think it comes down to, and I think you can be truthful without removing hope. Okay. And I think implicit in our training was this sense that at all costs, don't remove hope, because that's what people need. And I firmly believe you can do both. And
I do too.
That's maybe the crux of where it can start, to still be hopeful and still, explain both, hold out both. And it's also, it's a quality of life, right? I mean, think of people who make the decisions to stop, let's say, chemotherapy because they just don't want any more of all those side effects and would prefer to maybe shorten the number of days or weeks they have in preference for being less sick or the quality of life.
And I remember a Duke University medical study that those who've chosen not to take aggressive treatments in the last months of life live longer, more quality. And I recently I was in front of an individual facing end of life, and I printed off that research study for him because he was like, I really want palliative care. And I sat down with him and his partner, and I said, palliative care, community palliative care is a consult service. What are we focusing on, and we're going to achieve it. But the Mac Daddy Mercedes-Benz palliative care is going to give you in-home services and chaplains and social workers. It just happens to be called hospice. And a lot of people don't realize that hospice is absolutely 100% palliative care.
Yep.
But not all palliative care is hospice.
Right.
And I think we throw out these big terms like the H word and the P word. And I've been in a lot of medical schools, and I use this terminology called med speak. Even us in hospice, we tend to criteria, eligibility. People don't know these words. We're talking a whole nother language. And how do we get better with not dumbing down, but talking human being to people when medical decisions or even medical options are limited? How do we become better at that? Taking off the white coat and just talking to our patients as human beings.
I think some of it may be, well, certainly talking to our patients as human beings. I mean, that's a critical skill that ought to be part of the entire continuum of care, right? Unfortunately, maybe it's not always. But I do think in terms of the med speak, if I could just make something happen, it would be that people would be having educational sessions or learning about all these different options. People are so afraid of that word hospice. Does that mean I'm dying? Well, it's not as if you just became someone who's dying, right? I mean, that's
right.
A process. But I think if people understood that there's this whole continuum of things that can be addressed, and again, kind of make it part of the annual check your documents, and what's the difference between a living will or a caregiver, and have you really talked to your decision maker person? I mean, that's the place to start, is to just, long before issues arise, encourage people to identify a decision maker and to really have the conversation with that person. Again, everything changes when there's a diagnosis, but we've all seen somebody, there's a piece of paper and someone's told, hey, you're this person's decision maker. They have no idea.
No idea what they want.
No idea.
And it really does create a whole other set of burdens on that individual. But when you, like you said, your husband, Charles, this is what I want. This is my desires.
Yeah.
Suddenly the decision wasn't yours anymore.
No, that's why I say it was the greatest gift that he could have given us as a family. Nobody had to make a decision. It was perfectly clear what we were going to do.
And that healthcare proxy, that agents, when you sign up to be that voice, only when the patient cannot speak for themselves, by the way, we forget that we're not speaking for the patient. We're speaking as the patient. So we forget that. And I think that's very important, that forces, when you're speaking as the patient, you must represent their thoughts and decisions and beliefs and all of that wrapped up. And I believe that sometimes when that conversation does not happen, it's just a piece of paper. Let me just put it out there blunt. It's just a piece of paper that is worthless. And you're going to be sitting up in ICU and still having these burdens of what would they want? And I have no idea. And that I have seen destroy families. I have seen it destroy human beings. Did I do the right thing? Always question, did I do the right thing? And that's where I'm asking people who are in a diagnosis or doing advanced care planning. It is so important. If you don't have those conversations, it's just a piece of paper.
Exactly. Yeah. And there's so much opportunity lost, as we said earlier.
So much opportunity to be in the now, in the present. Like you said, mindful. Like, yes. And I just recently was with a family and I just told them, this sucks. It really does suck. Because we can hope that she can get into the wheelchair and go for a walk with you. And that's a good hope. But most likely that's not going to happen. But let's hope for that. We can hope for it. And it really choked the husband up, 63 years of marriage. And I told him, you have every right to be sad.
Yeah.
You're letting go of someone that you have known more than half your life.
Yeah.
And it sucks. But I cannot not speak the truth in a kind and a very not direct way, but direct way in a sense, because he's the first. Usually it's hospice and palliative care people that come in saying, hey, at the hospital, your doctor would like me to talk to you about hospice and palliative care. And they're like, what? And it gets shoved on to these individuals who are really good at conversations, but it becomes a shock factor then of, oh my God, no one told me.
That's just not fair. I mean, it's just not fair to anybody in the room. And it's hard to have those conversations, but I'm quite convinced that we could figure out a way to train our colleagues to do that. And it's just part of the work, right? You can't weasel out of that and put it on the social worker.
So talk to me as a family practitioner, which I think your internalist family practice, I believe that you guys can play a very, very valuable and even like turning the whole situation around, because you do see these patients for long term.
Right.
You know these patients. And hospices are arrogant too. They cannot walk in and be like, oh, our medical director is going to take over. We have got to include these family practitioners who have known these patients far longer and collaborate not only with the clinicians, but also with the patient and family all together. So where do you see, how can we expand the knowledge of hospice and palliative care and include these family practitioners, because you guys are seeing a lot. And when I was on tour in my RV and I would get lonely, I would go to like a family practitioner and sit outside their office, and the bags of medicine in grocery bags that they would walk into, because that physician's like, bring all your medications. I want to see them. I was just like, what are we doing? So how do you feel that palliative care and hospices need to be more inclusive with family practitioners at the clinics, in the office? How can we work better together, in your opinion?
I think that's crucial. And I know, at least in our hospital system here, the resistance is huge. It just is. Hospice is called in, I don't remember the statistics, but is it 72 hours is the average length of stay? What a waste of everybody's time and energy. You can't really be helpful to the patient in that period of time because you hardly know them. It's just a lot of paperwork, right? I mean, it's just
Cushion paper.
a total waste of the system and time, energy, all of it. It's got to be brought in or offered so much earlier, and people just don't know about. People in the community don't realize what palliative care means, and they're afraid of hospice. Doctors, I think, have tremendous resistance to calling in palliative care or hospice. And is that because they're not willing to deal with the truth? Is it because they want to maintain that relationship with the patient right up to the end? Is it because they think they are offering what's palliative care, right? It's relief of symptoms, and we all are trained to relieve symptoms. So to some degree, we all think we're all doing palliative care, which we're not in terms of end of life care. So
correct.
Again, I don't know what is being taught in medical education right now, but I still think the best approach is to community outreach, keep talking to people. That will change the system because people will.
They're going to drive it.
Yeah.
They're going to drive it, just like the birthing movement. And there's a lot of medical schools out there teaching their med students about end of life and conversations, difficult conversations. But we have to forget, where are those students going? They're going into and working with people who've been in this field 30 years. And I just can only imagine, when you're a new med student, you're most likely going to cave and be like, okay, let me do it his or her way, because they've been doing this for years.
Exactly.
And so it's a paradox for sure.
But I think the community activism, if you will, that brought the birthing movement. I mean, I love the developing, the emergence of the death doula.
Me too.
So that's going to help, right?
Because I hope so.
We just have to normalize the process, or the fact of, not even the process, but the fact of death, so that we can be talking about it. And when I don't do straight family medicine anymore, I do an integrative functional medicine, but I often talk with my patients about end of life. And I see people with some bad diagnoses who are looking for another approach. And I always have the conversation with them. And, every once in a while, somebody doesn't want to have the conversation, but more often than not, I find that it's like, oh, finally, somebody is opening space. Yeah. And permission.
Well, let's talk about your practice, because I saw your website, 5 Stones, and it's an interesting approach that I don't see in a lot of places, which I feel is at the community's detriment as well as the practitioner. Talk to me a little bit about 5 Stones.
So, as I said, I did conventional family medicine for 20 some odd years, and then had some opportunities to see things another way, is the way I like to say it. But so it's really an integrative medicine approach based on functional medicine, which really is a lot of terms. We really focus on looking at root cause and what we can do in terms of modifiable, mostly lifestyle factors that can contribute to changing a situation. Much less intense pharmaceutical medicine, a lot more integrative therapies, a lot of focus on nutrition, nutritional supplements, botanicals, herbs. We have a nutritionist, a coach, physical.
That's amazing.
Yeah, it's pretty wonderful.
It's amazing because, I've seen a cartoon in the last few months that you have like 100 people in the line to pop a pill. And then the other sign on the other window is change your lifestyle. And no one's in that.
Yeah.
Because diet, 80%, I think this is correct. If 80% of your health is what you eat and then put in your body.
I suspect that's true. I haven't heard that particular statistic, but I'm sure it's true. I mean,
it's amazing. So, what's your next project? I mean, you have this book out about your experience. Has it changed and in fact impacted the way you practice as a physician going through this walk with your husband, Charles?
Yes, in that I am much more willing to, and in fact, make sure I do, have hard conversations with people. Just they don't scare me anymore. I've done it.
Is it because of your experience though? And you're coming from a personal experience that you can share with your patients.
Yeah, I do. Right.
And I think people are desperate. And it goes back to your entire book. It was a story about.
It's really a love story. But
exactly.
Yeah.
A beautiful love story that in the end impacted everyone involved. And actually, after reading it, impacted it and made their lives better.
Thank you.
In my opinion, because it was so beautifully written about the story and how it just gave you a whole different perspective. And the thing is, you were open to that perspective. Not many people are. And
I hope to change that. I mean, I laugh and tell people that when you write a book, you pick a launch, maybe 6 months out or whatever. My book launched March 16th, 2020, which is the day the country shut down for the pandemic. Like, oh, good. That was really
yuppie.
So I'm relaunching it virtually next month November, on a virtual platform. But you asked what's next. What I really want to have happen is to help people have the conversations. I'll be doing some workshops and hopefully some speaking engagements. And, I just want to help get the word out about the fact there's a different way to do this.
Well, how can people get in touch with you to book you as a speaker? Or, how can they get in touch with you?
So the website would be great. My practice phone number, 703-669-6118. But yeah, the website would be the best way to do that.
Now, is that the Five Stone website, or do you have another? Yep. Oh, so go right to Five Stones. Yep. And your book is available on the website as well.
It is.
And
yep. It's all under one, right?
And I do think you provide something unique as talking and working for so many decades in the clinical world as a physician. You could have a major impact because of your experience. And so anyone who's interested, first of all, you've got to read the book, A Death Lived. It's an amazing love story.
Thank you.
But also get in touch and allow, get this wonderful person as a speaker, and it's going to impact your community. I think you really bring a good point, is that we have got to give the community permission to get into the driver's seat, because they're going to drive their own care.
And it goes right back to, it is their and each of our deaths to live.
It is, absolutely. Well, I want to offer, if there's anything that I can do, shoot me your virtual book launch. I will promote it on all my channels. I do feel very passionate when it comes to working with family practitioners, especially when you're looking at the unique integrative, what you've created right there in Leesburg, Virginia.
Correct. Yep.
I grew up in Richmond, Virginia, so I'm an East Coaster and I love Virginia.
Oh yeah. It's not far from Richmond. So.
Exactly. But I thank you for sharing your story. Thank you for being willing to have an impact on communities as well as the healthcare system in a whole. We're not going to change the entire thing, but we can change one patient at a time. And I think
absolutely,
that should be our approach. But I just have so much respect for you and your journey with your husband, as well as how you're allowing that to affect how you practice and have these hard conversations. It's going to take you and many other people to give community members permission to, again, get into that driver's seat and drive their decisions about their own lives. So thank you.
It's going to take all of us. Well, thank you. Thank you for having me.
You're an amazing person. I look forward. I might be in Washington in a couple of months.
Well, let me know.
I will love to get together and maybe have dinner with you.
It'd be fun. Yeah.
I feel like I can learn so much from your experience, and thank you for sharing that with us, with the book, with the podcast audience. Again, visit the Five Stones website. Get in touch. It's called A Death Lived by Martha Calihan, and she has been practicing family medicine for 20 some years, and so it's a unique perspective. So Martha, thank you so much for your time.
Thank you, Kimberly. I appreciate it. Take care.
Thanks for joining us today. And remember, you're the designer. This podcast is produced by Jason Andre with 7 Season Films. If you're interested in telling your story via podcast,